applause if you're happy with what I've said. I think, so it's great to see you all. We're here to celebrate the IDEAL programme, everything we've learnt, and think about how we can take it forward as regards improving the experience of dementia and enhancing active life. And almost all of you are here because you've been directly connected to IDEAL in some way or other, and it's wonderful to see you all. We do have a few special guests. I'm going to mention in particular Sophie Lewis and Robin Polisano from the Department of Health and Social Care. Thanks very much for coming along. Do have a chat with them if you get a chance. Welcome to everyone, and it is amazing to have you here. So the first thing that I need to do is to say a big thank you to our funders. We were funded in the first stage by ESRC and NIHR, and in the second stage as an Alzheimer's Society Centre of Excellence. And it's quite unusual to have funding for a large programme over such a long period. And that's allowed us to look in depth at this issue of living well. And if you recall, you cast your mind back when we started, and we started thinking about this in maybe about 2010, 11, and we'd had the dementia strategy, which was living well with dementia, and we wanted to think about, what does that really mean? And I wasn't really thinking about recent political developments when I put this photograph here, but also just to say that this funding originally was part of a commitment to social science research in dementia around the G8 summit in London in 2013, and so it's a real shout out for social science research and what it can contribute to understanding living with dementia. We didn't really expect to be here in 10 years' time when we started 10 years ago, but I thought I'd just show you this photograph of some of the team 10 years ago. A lot has happened to all of us in that time. And so I'll leave it to you to judge how the last 10 years has treated those of us that are still here. And moving swiftly on, hopefully now that we've been able to get Colin here to take photographs today, we'll have some wonderful photographs of 2024 and 2023 and be able to forget what we looked like 10 years ago. And the other thing that's been, I think one of the things that's been absolutely integral throughout IDEAL has been involvement of people with dementia and carers who support people living with dementia. And I want to thank our Always group. They were our original involvement group, and they named themselves Action on Living Well, Asking You Always. And we've learned a lot about involvement. I think we've progressed from more traditional methods of involvement through to real co-production and team working and partnership. And I think the thing that's also permeated the programme has really been the kindness and love that group has shown for each other as they've worked together. And it's benefited all of us. And it's very much here today, I think, with our group members here joining us. And so many of those people have stayed with us throughout. Some left for other reasons, and some have joined along the way. And it's great to see all of them here today. I'd like to take one moment just to remember Tom, one of our Always members who passed away last year. And he really brightened every meeting with his smile and his enthusiasm, and it brought him out of himself coming to be part of that discussion. So we're very pleased that Maureen, his wife's here with us today. She's also been an important part of the group. And Always was facilitated initially by Nada Savic and then by Rachel Litherland from Innovations in Dementia, our partner organisation. So we're very grateful to them. And I think without them, we would have struggled much more to achieve what we've done. So thank you. And then the Always group were also represented on our programme advisory group, which was chaired by Dr. Nori Graham. And that's included people from various areas of expertise along with Always group members, and they have been the most tremendous support to us throughout the project, and so I'm very, very grateful to all of them and to Nori. So I'm going to talk to you about the IDEAL research, and then we'll move on to other things during the afternoon. Before I start, I just want to say I'm going to show a lot of slides that are maybe quite detailed. They're plucked from various detailed presentations we've done about the programme. Please don't worry if they look very detailed and they're hard to follow or hard to get to the nitty-gritty of. They're just there for illustrative purposes, essentially to show you that we've done a lot of work. And I will be explaining the headlines of the findings as we go through. We have published, I'm told now, as of today, 71 scientific papers based on IDEAL. And I suppose this is a very good moment to say IDEAL is very much a team effort, and so a lot of what I'm talking about today, I'm saying everything on behalf of the team. The research team have put in a lot of work to achieve that level of output. People usually say to me when they talk to me about Ideal that it's been productive, and I think that's very true, and thanks to our team. I'm not going to go through all of those 71 papers today, you'll be relieved to hear, but as I said, I'll give you a few headlines. There is quite a lot to tell you, so it will be a quick ride through 10 years of research outputs, so brace yourselves. So on behalf of the team, let's go on. So it's a 10-year programme now, focused on living well for people with mild to moderate dementia who are living in their own homes or with others in the community. We recruited a group of people who we followed over time, and there were over 1,700 people with dementia, and over 1,400 of them had a carer also participating. And we did that thanks to the clinical research networks out there in the NHS sites who found them for us and went to see them and interviewed them and gathered lots of information, asked them loads and loads of questions, which they were very patient with. And we followed as many of them as possible over 6 waves of interviewing, mostly at yearly intervals, but there was a 2-year gap in the middle. I'll show you that more in a moment. And we also had some additional conversational interviews with a small number of them to go into more depth and detail. In the second phase, we had extra studies with what might be called underrepresented groups, people who aren't always included in research. So we've looked at people from black and minority ethnic communities, people living with undiagnosed dementia, that was in collaboration with the CFAS Wales study, and people with more severe dementia. So trying to be as inclusive as possible. But most of our work is about people with mild to moderate dementia and their family members. So what did we set out to do? Well, I had to look back at this 10 years ago, or probably 12 years ago that we wrote that now. We wanted to understand what's really important for living well for people with dementia and carers. And I use that term living well in a positive sense. I know it's not everyone's favourite term, but to me it means how can we make sure that people with dementia are flourishing and having a good life and living as well as they can and in the way that they want to and choose to do. So I hope you'll bear with me on that. We wanted to understand how people with dementia and carers influence each other in their well-being and how services and support are working with people to make living well possible. And we wanted to see what happens over time. How can we enable people to continue living well over time? And how might we know that someone's at risk of not living well? What could point us to the fact that they might need extra support or help? And we wanted to look at inequality and diversity. And we wanted to understand better how we can measure and monitor living well. And most importantly, we want to know how we can translate that knowledge into practical resources that could help to offer, hope really to people. Hope is very important. It's been a theme throughout Ideal that people with dementia and their families want hope for living with the condition. And our translation has 3 aims really. One is to be directly helpful to people with dementia and or carers. Another is to be used by people who plan and provide services, so commissioners, for example, or health practitioners. And then the last aim is sometimes to increase public awareness and understanding in the community generally about what it's like to live with dementia and what other people can do to help. And one element of that has been arts-based approaches. And our first arts-based project was the Unfurlings, where groups of people with dementia worked with artists, photographer Ian Beasley, poet Ian Macmillan, and the late cartoonist Tony Husband, to create what evolved into creating banners for hope and change, expressing some of the things people wanted to advocate for. Those were exhibited at the People's History Museum in Manchester in 2019, and they're also being published in a book, and they did tour the country, although slightly hampered by the pandemic. But you'll see some of the banners as I go through the talk. So just a summary of our structure. So as I said, we recruited people here, followed them a couple of time points, then we had a 2-year gap and we continued. And we recruited additional people at this second stage to make up numbers in the smaller groups. So for example, people with rarer dementias, people with young onset dementia and so on. And we were very much impacted by the COVID pandemic, of course. Up to that point, we'd been going out, the clinical research network staff had been visiting people at home, but we had to then, first we did a whole COVID study with our cohort, and then we had to move all our data collection online and talk to people over the phone and so on. So it really changed how we did things. But I think we learned a lot from it as well about different ways of doing things, and we were amazed by the resilience and the support of people with dementia who adapted and accepted different ways of doing it that might be less familiar. So, as I said, additional interviews and arts-based projects. We also had a very nice international meeting where we were able to meet with colleagues with similar interests in other countries. So this was the group of people that we recruited to our main study, the cohort study that we followed, where we followed people over time. Unusually, there were slightly more men than women, so we got the idea that wives are probably very good at getting their husbands to take part in research, but not so much the other way around. In terms of age, they were quite varied. We did have the majority being aged over 80, which is as it should be. We also had about 11% of people under age 65, so that's quite important to comment on as well. In terms of diagnosis, about half had a diagnosis of Alzheimer's. The distribution of different diagnoses was more or less what we would expect from estimates that had been made for the UK population. And although in some ways it was not necessarily very diverse, so for example mostly white British, in many other ways they were a very diverse group in their own characteristics and experience, and certainly in the way that they answered the questions, so we had a great range of responses. And we asked people if they had a family member or a carer willing to take part, to invite that person as well. So our carers, not surprisingly, were mostly female and mostly wives or husbands or partners of the person with dementia. But the age distribution was a little different because we did also have a contingent of adult children, of course, who were supporting their parents. And when we started, I guess like all good researchers, we started with a review of what's known already. We did a systematic review. And that showed us, well, essentially, surprisingly, not very much. It told us that an awful lot of things have small links with being able to live well with dementia when they're measured at the same time. It didn't really tell us about what might signal that someone was at risk of decline in ability to live well. And there was no real overall picture. And we were very fortunate that our advisory group advised us to start by focusing on that big picture and how everything was working together to shape whether someone was living well. And we did that, in fact. We went on and did that, both for people with dementia and carers, but I'm going to focus more on the people with dementia just for now in this talk. So the first thing we had to do was develop a framework for studying living well. We had a lot of discussions and debates about concepts and measurement, and we knew that we wanted to take a broad approach. So we thought, for example, about the World Health Organization framework, which I've put here, which focuses on how people manage to function in their life, what they do and what they're able to do, and the whole range of things that affect that and affect whether they're included and whether they're able to engage in activities and participate in their communities and in society. And certainly a health condition is one thing that affects that, but it's far from the only thing. So people's own characteristics and their own resources and their context, their relationships, their social situation, the environment they're in, all have an impact and a role to play. And we know that dementia poses challenges partly because symptoms make things harder, but it's also because of the wider impact. For example, make you feel anxious, or you lose confidence, or because other people react negatively, maybe they walk away from you or they don't engage with you anymore, or because the environment's not well adapted. We had a lot of conversations about this morning. When you go out, can you find the bench to sit on, or the toilet, or whatever it is that you need? And sometimes communities just aren't very inclusive. In fact, in our data, we asked, the carers told us about whether they lived in a dementia-friendly community, and whether they thought they lived in a dementia-friendly community or not. And actually, exactly half said yes, they did, which is great, but the other half said no, they didn't, which is not so great. And so we've still got work to do to make communities more inclusive. So we thought about living well as a balance between these sorts of challenges and the resources that you have. So resources might be things like a positive outlook and a good sense of humour, or having a good network of friends, or having enough money, or being physically fit, and so on. So we tried to understand it as a sort of balance, if you like. And we also drew a lot on the Institute of Medicine work on living well, which emphasised again this importance of a sense of comfort and security, feeling safe, feeling satisfied with your life, a sense of well-being, and essentially everything that adds up to a good quality of life. So this is how we evaluated living well and the things that influence it in Ideal. We asked people about their quality of life, their well-being and their satisfaction with life, and we used questionnaires for that. And sometimes you'll see me mentioning one or other of those, or I might be talking about all three of them grouped together. We also had an open question: what does living well mean to you? Our Always group were very keen that we should include some open questions, and it was very good advice, and that was one of them. And we had in-depth interviews with a subset of those participants to understand a little bit more about their everyday experience. And then we had a look at resources that people had in various different areas of their life. So physical health, their psychological or emotional well-being, the social resources they have, so their social networks or social activities, their social situation, are they, for example, living alone, or do they own a good neighbourhood, and how they're managing everyday life. So they're dealing with the challenges of those symptoms. And then we looked at how the person and the carer influence each other's well-being, and we looked at changes over time. So the advice to look at the big picture was very good advice, but it was quite a headache for our statistical experts who had a big challenge to make sense of all that data. But they rose absolutely to the challenge and gave us a model for how the various domains of life and people's experiences and resources are linked to being able to live well when everything's measured at the same time. So for those of us with less statistical brains, we can also think about this in a slightly different way. So in this picture, you can see each domain listed and then the bars next to it. And the bars show, the orange bars show how strongly that domain, or the things people told us in that domain, is linked to living well. And so when you look at those orange bars, you can see that each domain is linked to living well. They're all important. Then the blue bars show us what happened when we, if you like, you put all of that information together of the different domains into the statistical model, and you let the domains fight it out among themselves as to which one's most important. And when we look at those blue bars, what we can see is the psychological one stays very important. So that's absolutely crucial. It doesn't mean the others aren't important, but what we think it means is that those experiences and all those other aspects of life affect your psychological well-being, and your psychological well-being is then very close to how you feel about your life and whether you're living well. So psychological well-being is really crucial, but that rests on lots of other aspects of your life. So that was first thing, and then we wanted to know, okay, if we can measure living well, how does it change over time? And this was another challenge for our statistical experts. And actually, when you look at it like this, if you take the average scores for the group over time, it doesn't change a great deal for the people who stayed in the study. It's possible that those that didn't continue, of course, had a different experience. But within that group average, it's slightly better for women than men. So, but within that group average, there was an awful lot of variation among the different people when we look at them as individuals. And so a little bit more exploration helped us to understand some of those things that might signal to us, I should be concerned about this person because I think they're at risk that their ability to live well is going to decline. And what we found that, again, those psychological aspects come out as very important. So if we see people, when we go to visit them 1 year, that are saying they're a bit more depressed, they're feeling low, they're not feeling so good about themselves, they feel like they're not the same person as they were, and they feel lonely, all of those things could signal that the next time we see them in Ideal a year later, their quality of life score will have dropped quite considerably and quite meaningfully. So again, that emphasises this importance of psychological well-being for living well, and how if we want to make sure that people continue to live well, we have to make sure that their psychological well-being stays good. And that, as we've seen, rests on doing well across all those other domains of life. So it is a very broad picture. So please don't worry about this. This is my, just to remind me to say, this gave us the initial idea of a living well map. So this is how it started to evolve. If we could put all those things together and draw it out as a diagram, how would it look? So what we then did was to look in each of those different domains of life in more detail to try and fill out what was important for each one. So I'll just give you some examples. Physical health is one. A lot of our people with dementia had other health conditions, and what we can see is if you map the number of health conditions that they have from less to more, the quality of life scores drop the more health conditions you have in addition to dementia. So physical health, clearly very important. And then if we think also about how well people feel they're managing their everyday activities, this is exactly the same picture. So the harder it gets to manage everyday activities, the more the scores decline in living well, whether that's quality of life or well-being or satisfaction with life. And of course, managing everyday life is so central to this. And through our Art Space project, this group in Bradford wanted to raise awareness of the need to make the technology we encounter when we go out and about user-friendly, like ATMs and so forth. And this group in York wanted to raise awareness of the need for public transport to be accessible and user-friendly so that people could get out and about and have what they called a grand day out. And, you know, we've heard about this recently, haven't we, with ticket offices closing. And that group held a public unfurling of their banner on York railway station to really try and make the point with a brass band and everything. So they really wanted to campaign for that, being able to get out and about. Coming back to psychological health, loneliness, a huge problem. If you feel lonely, about a third of our people with dementia in Ideal said they felt lonely. If you're lonely, your well-being score is going to be less than if you're not lonely. So as loneliness increases, so well-being decreases. And this group at Age UK Exeter wanted to raise awareness of the importance of friendship and how groups like their Budding Friends gardening group can make a difference for people who enjoy gardening, not all of us, we discussed this morning. It's about finding the right thing that works for you, of course, but this group were keen on gardening. In fact, they did other things in the winter, but this lifeline of support really for people who do feel lonely and want to get out and make social contact but find it difficult. And this group and others like it struggle, of course, to secure funds to keep going, but it is really important that these things are happening and out there and giving people opportunities and choices. Then another thing we thought about, this was not so much one of the domains, but we were thinking about other influences on living well. And one is how people adjust to getting a diagnosis. It's a whole process that you go through when you're given a diagnosis and then have to come to terms with it in some way. And what we know is that people develop their own understanding of a condition when they get a diagnosis. And we were able to group people together based on what kind of understanding they developed. And that understanding shapes how you cope, of course. And I just want to mention one finding from this, which is quite intriguing, which is that people who thought about dementia really as a sort of part of getting older and something that you might perhaps expect, were doing much better in terms of their quality of life and well-being than people who thought about it as a disease, a medical condition, and used terms like Alzheimer's to talk about it. So that's a very interesting one that we could debate a lot, I'm sure. And we found that stayed the same over time too. And thinking about adjusting to the onset and diagnosis of dementia, that was something that related to one of our art space projects. It became a theme. This was The Bridge. We secured funding from the Arts Council of Wales and worked with director Marion Brivdir and composer Ed Wright to develop, perform and film a new one-act opera. I'm just pausing here to say I actually had no part in this other than the idea of it because I can't sing or act. But we had an amazing cast, and our Always group advised them. And this opera was the idea of it was to promote understanding and reduce stigma. And so it portrayed a couple where the husband was diagnosed with dementia, and then thinking about how they managed and got adjusted to that. And was very powerful discussions with the audience afterwards when it was performed. It's now available on YouTube if you would like to look at it. This thinking, though, about how each member of the couple responded and how each of them influenced the other, we knew from our research that how, for example, how the carer feels influences the person living with dementia. If the carer is very stressed, person with dementia will pick that up and will probably have lower well-being as a result. But we sort of wanted to go a bit beyond that and think about how the experience of each did or didn't affect the other's well-being. we used, when I say we, in the very much the royal we sense here, different new statistical models called actor-partner independence models to understand this better. So I'll just summarise this. It's quite interesting. So for the person with dementia and the carer, we know that their own depression, loneliness, isolation, and feelings of relationship being poor quality, if they have those things, affects their own well-being. That's true for each one. But interestingly, if the person with dementia feels depressed or lonely, that affects the carer's well-being, but not if they're isolated or think the relationship is poor. And for the carer, if the carer's depressed or isolated, that affects the person with dementia's well-being. But interesting, not if the carer's lonely or thinks the relationship is poor quality. So this is really interesting because it tells us a lot of things, but one of the things it tells us is that if we're able to help one member of that couple, we're going to probably do some good for the other as well. And so that can help us to think about how we work with people and couples, or perhaps if one is not very keen to receive support or engage, the other might be, and so we can perhaps find a way there to be helpful. And this encourages us to focus more on communication in these close relationships. And that was the focus of another arts-based project. This was The World Turned Upside Down. We worked with the theatre director, Paul Jepson, and a cast of actors, and the Always group advised them. And the idea here was we developed a set of scenarios about different transition or key crunch points, if you like, in the experience of going through having dementia or supporting someone with dementia. And the audience and the actors improvised scenarios around this. That might have been stopping driving or eventually thinking about moving into a care home, for example. And they would enact those scenarios, and then in the performance, the audience were invited to comment, and then they were able to suggest perhaps different ways of communicating that might lead to different outcomes that might be better. And so we were able to make a film about this, a documentary film about the process of rehearsal, developing the scenarios, and actually performing them it was performed 3 times in Exeter. And then the film is now available. It's been downloaded viewed a lot on YouTube, but also being used in public screenings where you can then have a discussion afterwards. It can be used in screenings for groups, for example, carer groups or groups for people with dementia. And the scenarios can be used for training and CPD purposes as well. So they're being used to train practitioners in perhaps by showing them how not to do it, ways that might work better of communicating. So again, back to this detail, and now you'll see it's all fleshed out, and this was helping us to fill in the detail of our living well map and how lots of different things contribute to whether or not someone's living well. And this works in my head, but it won't work for anyone else. And well, mostly works in my head. It's a bit hard to keep track of. What we're trying to do now is take that map, which contains the summary of all our findings, to co-produce a resource that can be used by people who plan and provide services. So, for example, commissioners or practitioners in health and social care. And we're working with them to produce something that will help them to know this evidence and what they can do to implement it. So that's an ongoing piece of work which we hope will come to fruition fairly soon. And we are doing the same process for carers. We went from this statistical model to an even worse looking living well map, which again is now part of that process, to produce a parallel resource that can be used in practice. And again, just a reminder that we often talk about both people with dementia and carers as if they're one group. And we really shouldn't be doing that. We need to think about diversity and how the different people can be, and to think in a much more personalised way about how we provide support. And reinforcing the importance of support for carers, our Oldham Springboard group developed this banner, which was very much giving that message. And we've been fortunate with Ideal and our close relationship with Alzheimer's Society to contribute to some of their work, and their policy report on carer support was one of the ones that we were able to provide evidence for. And of course, carers are providing most of the support and covering most of the cost of support for people with mild to moderate dementia living in the community. And what you can see here is the blue part of the bar is the paid services, and the orange part is the estimation of what carers, family carers, informal carers are providing. And that was at our first time point. And then over time, you can see that, yes, the blue line goes up a bit, but the orange line for the unpaid support goes up even further. So just a real reminder of the importance of what carers do. And we talked this morning about that, but of course it is a reciprocal thing, and carers are giving a lot, but people with dementia are also giving in that situation. And so this is very much a two-way process. But we do need to look after our carers. Both carers and people with dementia are trying to navigate those services and get support. And one reason why that blue bar wasn't very high might be because sometimes it feels like a confusing maze, a bit frustrating. And the Kirklees Deep Group wanted to highlight that in their banner. And we looked in Ideal at what services people had received. We found that people in general were receiving not very much support from formal services. And only about a third of them said they had a named person that they could contact. Often that was for a different condition, such as diabetes or something like that. But we also found some evidence of inequalities. For example, older women with fewer educational qualifications were less likely than others to receive services and support. And that evidence was used in another Alzheimer's Society report on left to cope alone on post-diagnostic support. So moving on to focus more on diversity and inequality, I just want to pick up on a few angles here. So first of all, as I said, we shouldn't be thinking about people with dementia as one group. People have different diagnoses and those present different challenges. And we looked at whether living well, capability to live well differs by diagnosis, and the answer is it does. And what I'm going to just highlight here is these two bottom lines represent people with dementia with Lewy bodies and people with Parkinson's disease dementia who are reporting much lower quality of life than people with Alzheimer's disease at the top. So they may have, we really need to think about the specific needs of different groups. Social disadvantage, the area that you live in. We were able to look at areas in terms of their relative advantage or disadvantage and deprivation level, if we could put it that way. And we grouped areas from least to most deprived. And you can see again that scores for quality of life, as we go from the least to most deprived area, the scores get lower for quality of life. And then living alone. That's another thing. We'd sometimes thought that has to be a negative. It's not necessarily a negative thing. But we do have quite a lot of people with dementia living alone, and there can be particular challenges. We had about 18% of our participants at the outset of the study were living alone. And a small proportion of them, about another 18% of that 18%, seemed to have very little support from any family or friends. People did have some advantages. People living alone tended to be better able to manage their everyday activities, and they had more social contact outside the home than people living with others. They were more likely to use assistive technology to help them. But they were also more prone to depression and more likely to feel lonely, and they tended to have a poor quality of life. Also, people in Black and South Asian communities experience more challenges for living well. So we found that people with dementia in those communities had poorer quality of life and were more lonely than their white British peers in the cohort. And the carers tended to be more stressed, to feel more trapped in their role and to have less positive things to say about their relationship with the person with dementia. And these people were experiencing dementia in the context of a lifetime of feeling they didn't belong, of experiencing discrimination and instances of racism. And then within the communities, there was also differing levels of knowledge and attitudes about dementia that made things difficult. And the service provision that they had access to was not always culturally sensitive or so well trusted. And this South Asian group, Hamari Yadin, in their banner, asks simply, when we talk, will you listen? They were thinking also more specifically about losing skills in their second language, which was English, as their dementia progressed. So this focus on diversity does remind us again of the importance of a personalised understanding of each individual. So building on that, we have developed some resources to support that. This is one example. We work with the co-production group, the DEAR group, Dementia Experts into Action Research was how they named themselves, to co-produce and validate a questionnaire that captures the extent to which someone is living well. It takes those different domains and in the Living Well map and asks about them. And that allows us to see for that person what's working well and less well, and perhaps what might help to improve things. We used the answers to our open-ended question on what does living well mean to you, and we generated a long list of possible items, and with the DEAR group we worked through that, through several rounds of reviewing and then testing with our cohort, and we ended up with a scientifically validated 10-item questionnaire, and the layout was co-designed by the DEAR group to make it user-friendly for people with dementia. As I think Chris said, it should be something that I would want to fill in, and that's how they were thinking about it. That's now available. It's publicly available with no charge to use, so anyone can use it. Ideal's given us a lot of valuable evidence. It was particularly helpful at the start of the COVID pandemic, where we were able to spring into action and produce evidence-based information and advice for people with dementia and carers. And that was translated into 10 more languages by the Race Equality Foundation. We were very pleased about that, and we hope that it reached a lot of people. And that was the basis for one of our most important outputs. It evolved into what is now the Living with Dementia Toolkit. This is an online resource, but we have printed guides available in English and Welsh. And this, again, it takes those domains in the Living Well map and it translates them into everyday terms. Stay safe and well, stay connected, keep a sense of purpose, stay active, and stay positive. And each topic has a lot of resources to provide ideas, inspiration, and hope for people living with dementia. And I'm very proud to say that it's been accessed currently by over 23,000 users from 130 countries. It's included in a World Health Organization resource, the Global Dementia Observatory Knowledge Exchange Forum. Within the UK, we know that this is being used by GPs, by memory services, by older people's mental health teams across at least 20 integrated commissioning boards, and by a lot of community and third sector groups. So we hope that it is bringing information and hope. It was co-produced by a group of 4 people living with dementia, 4 carers and 2 professionals, who met fortnightly for 7 months and then continued as needed to keep building the resource. And I think they had a good time doing it. And there was certainly a lot of benefit in that mix of people. And one, for example, having those perspectives coming together really gave us a unique way of looking at things. For example, how we approach the topic of risk. This is something where people with dementia and carers often have very different views. But by talking about that and coming together and thinking through the issues, they were able to arrive at a resource that they all felt happy with and that reflected the range of views that they had. And the toolkit contains several standalone resources. One example is My Life, My Goals, developed by people with dementia based on another set of research around rehabilitation or reablement that we've done. And it supports people in making everyday life more manageable by developing strategies to tackle some of the challenges. Something people can use themselves or with a family member, but it's also being used by practitioners. For example, Reinhard Guss, who's here somewhere from our advisory group, we know he's using it. We're working with him on this to support people in the Oxley's memory service. And it can augment what a service is able to offer where resources are limited. Coming soon, another one will be My Life Today. And this one is designed to help people notice what the things are, maybe even little things that help them to live well, and track whether they're managing to include those things in their everyday life, and then make any changes needed to ensure that they are included if that's a gap that they identify. And they can share this with others or do it on their own as they wish. And we're co-producing that at the moment. We currently have 20 people with dementia testing My Life Today. We're talking to them about their experience of using it and to any people who supported them to use it. And this is so that we can find out whether it works well or whether there are any changes that we need to make before we put it on the toolkit. And then, as I've mentioned a few times, hope has been a very important theme in Ideal, and it's very much the theme of the Ideal song. Not many research projects have a song, but Ideal even has a song, and it was composed and performed by Tommy and Paul, who are two musicians living with dementia. And we were very proud to see it adopted as the official song of the Alzheimer's Disease International Conference in last year, where it was played during the meeting in the breaks between talks. And this is very much again about hope and support and care. And in the words of the song, which are addressed to people living with dementia, we all stand beside you and hope in your heart will see you through. So there are also still to come. Our funding remains open for some work to be completed in the next 6 months. We've got a few key scientific papers to do. I've got one sitting in my inbox at the moment about inequalities. We've got a review about living well with more severe dementia, and we've got that work on My Life Today. And also, after about a 9-year battle with bureaucracy, we finally secured permission to link our cohort data with routinely collected data on health service use. So we'll be able to understand much more about the health services that people in our cohort have accessed and used, and probably understand also more about some of those inequalities in accessing services, which we're very excited about being able to do. It was a bit of a marathon over 9 years trying to get permission. I'm sure it'll be worth it in the end. And then the last one I want to mention really is the book, The Ideal Book. This is, again, a co-produced effort with our Always group. It's going to be a manifesto for living well with dementia. It's called Living with Dementia Reconsidered. It's a book in the Rethinking Dementia series with the Open University Press. And it covers the ideal evidence and combines that with reflections from people living with dementia and carers from the Always group and others. And it's going to create a manifesto around those domains that we found, that we've looked at, about what's important for living well and what people with dementia and carers feel needs to happen to make sure that they can live well. So that's due to come out next year. Ideal Ending is going to leave a big hole in our hearts and lives for us researchers, and perhaps for some of you as well. But we're not stopping here. I'm really pleased to say that some of the research team have been able to link up with other colleagues and find a way of putting our experience in Ideal and other areas to good use. And we are very happy to be funded as an NIHR policy research unit in dementia and neurodegeneration starting in January. And we have some really exciting projects planned. And we're very much looking forward to that. And what I want to say is, for any of you that have been involved in Ideal who feel you're going to miss it, if you want to join us on this new journey and support the new research, there's lots of scope for involvement. And we really want to make sure that we are hearing what's important to people and getting people's views. We would be absolutely delighted to have you along. So do think about that. And it just remains for me to say a huge thank you. It's been the most tremendous privilege and pleasure to lead Ideal, and a joy to work with you all. So thank you very much.